Do I need a mic? Are you guys mic?
For Hopkins, it's just these.
Okay. I checked.
Sorry, I'm cold. I didn't go.
So are they gonna count us down or?
Go ahead and start.
Good morning, everyone, and welcome to today's program celebrating American Indian Alaska Native Heritage Month. I'm delighted to be here this morning. My name is Deidre Gifford. I'm the Deputy Center Director at the Center for Medicaid and CHIP Services here at CMS, and I am the executive sponsor for this morning's event. We're very pleased that you're able to join us here in Baltimore, and also welcome to those of you in Washington, D.C., and to our regional offices via YouTube. This year's theme for the program is Partnering Across Nations and Generations, Supporting Healthy, Sustainable, and Thriving Native Communities. As you may have heard in the video, if you tuned in a little bit early, titled Role of CMS in Indian Health, Indian Health Services, which is a sister agency of ours within HHS, has the primary responsibility of providing health care to American Indians and Alaska Natives in 47 hospitals and over 600 health centers across the country. In conjunction with these efforts, CMS also plays an important role in improving health care to American Indians and Alaska Natives through enrollment in Medicare, Medicaid, and CHIP, and the Marketplace, which brings much needed third-party dollars into tribal communities and increases access to care. Despite our efforts, though, American Indians and Alaska Natives continue to experience greater health disparities than other Americans. And for this reason, the work of the Johns Hopkins Center for American Indian Health is so important. And we are really pleased to be able to partner with them to bring you today's program. Today, the Center for American Indian Health will speak on engaging the strength of community to promote health. It's my pleasure to introduce to you our panel of speakers for this morning's event. First is Dr. Mary Cwik. Dr. Cwik is the Associate Director at the Center for American Indian Health at Johns Hopkins Bloomberg School of Public Health. She's joined this morning by Dr. Victoria O'Keefe, an assistant professor in the Center for American Indian Health and a member of the Cherokee and Seminole Nations of Oklahoma. And by Kenney, a research associate in the department. We welcome all of you, and we thank you for taking the time to join us here at CMS and sharing your expertise today. Your center is doing amazing work to improve the lives of American Indians and Alaska Natives everywhere. As a result, you've inspired many young people to work within their tribal communities to help improve the health status of their people. We're very happy to call you a partner in our efforts to support healthy, sustainable, thriving Native communities. Please join me in welcoming the Johns Hopkins Center for American Indian Health, and I will turn it over to Dr. O'Keefe, who will begin our discussions.
Thank you, and thank you for having us here. We're very excited to present about our Johns Hopkins Center for American Indian Health. I want to start by providing some background. Many of you may be familiar with some of these statistics, but it's good to give some context before we jump in about our center. So American Indians and Alaska Natives today, we have information about the population based on the census. And it was actually not until the 1980 census that we had American Indian Alaska Native demography information. According to the 2010 census, there are approximately 5 million individuals who self-identify as American Indian Alaska Native alone or in combination with other races. This constitutes approximately 1.5% of the US population. There are approximately 2 million American Indians and Alaska Natives that live on rural reservations, and the majority of those are west of the Mississippi. Today, there are 567 federally recognized tribes, as well as hundreds of state-recognized tribes and tribes without federal or state recognition. And these tribes are distinct in culture, and that's something to keep in mind, as this is a diverse group of tribes. And there are more than 150 native languages still spoken today. Unfortunately, we see that there are a number of disparities on reservations with American Indian and Alaska Native youth. You can see from this slide a number of concerning disparities, including death rates that are 3 times higher among infants up to young adults, suicide and alcohol-related deaths that are 2 to 7 times higher the general population, as well as higher rates of obesity and diabetes, school readiness, and higher rates of high school dropout. Teen childbearing is 2 times higher among some reservation communities, and unemployment rates that are 50 to 80% higher in some reservation communities. However, not highlighted in this slide that I think is really important to emphasize and part of the theme today are the strengths and resiliency within Native communities, including reservations and urban communities. So our Johns Hopkins Center for American Indian Health is housed in the Bloomberg School of Public Health, and it was founded in 1991 by Dr. a.m.to based on 10 years of work with Southwestern tribes. And the mission of our center is to work in partnership with American Indian and Alaska Native communities to raise American Indian Alaska Native health status, self-sufficiency, and health leadership of American Indian Alaska Native people to the highest possible level. And we're going to show just a brief video that highlights some of the work and provides a good overview of our center.
In the beginning, the healthiest and best stewards of the planet lived here. They lived in concert with land and seas. In the beginning, the healthiest and best stewards of the planet lived here. They lived in concert with land and seas, developed hunting and farming techniques. They created art with deep meaning, and they passed down stories and cultural practices with power to preserve our planet. At that time, the first Americans and the earth thrived. Today, Native peoples are suffering from the poorest health, education, and economic status in the United States. The Johns Hopkins Center for American Indian Health was founded to restore American Indian well-being and share our solutions with the world. 35 years ago, when a young Johns Hopkins pediatrician learned that American Indian children died at rates 10 times the U.S. average, his life, and millions of others, changed forever. In 1980, Dr. a.m.to began research with the White Mountain Apache on oral rehydration solution. Apache outreach workers taught parents to use this solution with sick babies in their homes. It stopped widespread deaths from diarrhea and vomiting. Today, it is known as Pedialyte. Their discovery was sent around the world. An estimated 50 million lives have been saved. In 1991, under Santosham's leadership, Johns Hopkins founded its Center for American Indian Health. Research continued. Navajo and Apache tribal partners helped prove new vaccines against meningitis, rotavirus, and pneumococcus, deadly germs that attack Native children at extremely high rates. American Indian children were the first to get the new vaccines, which now benefit children across the U.S. and the world. In the next next decade, more than 5 million children's lives will be saved worldwide. Behavioral and mental health issues now pose the greatest threats to American Indian communities and the world. The center is working with tribes to tackle suicide, diabetes, obesity, drug abuse, HIV, and AIDS. With the White Mountain Apache, the center is pioneering suicide prevention strategies. Native mental health workers track surveillance data and scour the reservation to reach youth at risk. They counsel them through challenging times and connect them with elders who teach traditional values about the sacredness of life. They recreate a web of hope. The center is now scaling this model across other communities. Because the roots of mental and behavioral challenges are early in life, the center's Family Spirit program was created to serve expectant mothers and their children through home-based parent training. The center has proven that Family Spirit mothers overcome depression and substance use while increasing parenting skills. Their children benefit from healthier social, emotional, and behavioral development. More than 55 tribal communities are now using Family Spirit. The city of Chicago is the first to adopt Family Spirit for Latino and African American families. Over the next 5 years, the center plans to reach 100,000 more families. The center is also working to end childhood obesity and diabetes. Feast for the Future works to ensure long-term cultural transmission of farming techniques and traditions to encourage healthier lifestyles and reduce diabetes. Family health coaches trained by the center prevent diabetes through home-based education on nutrition and fitness. Using sports as a hook, Native Vision taps the power of positivity to link children to healthy futures. Over the past 20 years, Native Vision has reached thousands of children through camps and after-school programs. Thousands more await. The newest light on the center's horizon is the Youth Entrepreneurship program. With unemployment rates as high as 80% in some tribal communities, kids are losing hope. Resources and talent from Barclays Bank have helped the center build a model that blends business and life skills training with cultural empowerment. Results show kids are staying in school, getting jobs, and starting businesses. At the core of the center's mission is training the next generation of Indigenous health leaders. From high school through postdoctoral training, Johns Hopkins Center for American Indian Health is supporting a pipeline of education. 500 Native scholars will graduate in the next decade. For a quarter of a century, the Johns Hopkins Center for American Indian Health has been overcoming health disparities with its tribal partners by blending cutting-edge science with profound cultural strengths. This work deserves a future. With your help, we will restore the well-being of the first Americans and our planet.
I really like that video because we can talk about all of the programs and the work that we do, but it's really powerful to see it in action, see the photos and see it through video. And we've been fortunate at the Center for American Indian Health to have partnerships with some Southwest tribal communities that have been in existence for more than 35 years. So some of the tribal partners we've worked with the longest include the Navajo Nation, the White Mountain Apache Tribe, the San Carlos Apache Tribe, and Santo Domingo Pueblo. As was mentioned in the videos, our 3 core areas at the center are focused on training public health scholars and Native leaders, infectious disease prevention, and behavioral and mental health promotion. And we're going to talk about some of our programs within these 3 areas. And today we have relationships and partnerships with more than 100 different tribal communities across 16 different states. So our work over the last 3 to 4 decades has really expanded across the country, and we're really proud of this work that we have with community partnerships. And throughout our work, we are really focused on employing Native staff to do outreach and health research within their own communities, as well as Native faculty to assist with training Native scholars at Johns Hopkins. A few more facts about our center. We have more than 120 employees. Our staff with American Indian heritage are about 60%. And we've trained more than 400 Native community health workers to date. And a few of our major accomplishments, I'm not going to go through all of these, but we have programs that have spanned infectious disease, mental and behavioral health, youth entrepreneurship, nutrition, and our scholars program for training. And we're going to talk about some of these in detail today. And I'm going to turn it over to Anne to talk about how we're able to achieve many of these accomplishments and start talking about some of our programs.
Great, thank you. So when Dr. Matu Santosham first moved out to the White Mountain Apache Reservation, he was moved by the strength and resilience within the community. And this strength and resilience, you'll see, is a key component of many of our projects. One example is the use of paraprofessionals, folks from the local community to serve as interventionists for a lot of our programs. And truly we believe that these local interventionists are the secret sauce. They're trusted by the community members, compassionate, the true definition of a community change agent. They have connections with the health system and know how to facilitate those connections. Local workforce development. Victoria mentioned that in some of the communities we work, there's unemployment rates as high as 80%. So this is a great way to build the local infrastructure. Also feasible for dissemination and scaling up. There's a ready workforce that can be trained to do a lot of this work. For the next part of our presentation, we're going to tell you a little bit about our projects that work across the lifespan, starting with some of our early prenatal, early childhood projects up into the projects that focus on the later years. So our infectious disease prevention program has a variety of different projects. A lot of them focus on infants. We do a lot of epi-clinical trials and disease impact studies. I want to point out this graph right here. Some of our early work in the 80s focused on Haemophilus influenza type B. And you can see from the graph that rates were much, much higher among the communities that we were working. And our team really worked to evaluate the efficacy of a novel vaccine. And after that was established, really worked to roll out the vaccine to all the community members. And you can see after it was introduced, there was a major drop in disease rate with rates that mirrored what we were seeing in the general population. So again, our infectious disease approach, we mainly work on topic areas that have a disproportionate burden in the Native communities. We focus on prevention and treatment and do a lot of ongoing surveillance so that we can measure the impact of the work. And here's a quick snapshot of all the different areas of our infectious disease research. And I'm not going to read through all of them, but you can see that we span a lot of different topic areas, oral health, gastroenteritis, indoor air quality, and work on a lot of different pathogens, so rotavirus, influenza, RSV, etc. And as you all know, there's been a changing landscape, and I think our center has seen this over time. There was a true persistence of infectious disease, and there has been a shift, and I think a lot of the communities we're working with are acknowledging the importance of some of the behavioral and mental health challenges. So we have focused a lot of our work on those topic areas. One of the programs I think you all saw in the video is Family Spirit. This was one of our first behavioral health programs, started in the early 90s. So over the past 25 years, it's really been expanding and changing in scope. But today, it's an evidence-based home visiting program. It's 63 different lessons delivered over 3 years. We engage local paraprofessionals who work with mothers starting prenatally until their child turns 3 years old, and works on a variety of different topic areas. So they teach the mom how to care for their child, but then also really focus on psychosocial, emotional well-being, budgeting, life skills, topic areas that are relevant to the mother. And we do keep expanding this curriculum based on needs and wants of the tribes. And we've evaluated this program through 3 randomized controlled trials. And we've been really happy to see that there have been great outcomes for both the moms and the babies in different parenting domains, knowledge, self-efficacy, stress, home safety attitudes. We see a decrease in mothers' depression, substance use, and for child outcomes, fewer emotional and behavioral health challenges through age 3, and lower clinical risk of behavior problems over the life course. The Family Spirit has grown so much over the past 20 years. In the video, which I think we made a couple years ago, I noticed it said that we're in 50 communities. We're now in over 100 across 16 different states. And we're also in 2 non-native communities. So I know the video mentioned Chicago, but we're also in St. Louis. And we're also exploring ways to expand to other non-native communities. In some of the trainings, we've met with folks in Chicago and have asked them, how would you like to adapt the program for your community? And they see so much strength in a lot of the native culture that they actually don't want to change it. So it's been really neat to see that and how the different communities have worked together. And then we're also in 10 Indian Health Service sites. And as I mentioned, we're continuing to expand our early childhood family spirit work. One of our newer projects is really enhancing the early childhood obesity components of family spirit, focusing the curriculum on responsive feeding, early physical activity routines, and maternal psychosocial risk. So we have an R01 right now where we're developing these components, and we're going to evaluate their efficacy. And we began developing this curriculum in 2015 thanks to a grant from the Navajo Indian Health Service. So we're excited to see this new initiative come to life. And I'm going to pass it over to Mary, who's going to talk about our middle and later childhood interventions.
Great, thanks, Anne. I have the honor of talking to you guys about a whole host of programs really in the adolescent years, which is a group that our center has really focused on for a lot of reasons. As we know, adolescents are at risk for lots of different behaviors, but they're also at a great age for prevention, right? Trying to prevent and get healthy behaviors in place before they become adults and getting them on that healthy path. And many of these you will have seen in the video highlighted, and I'll give you guys some additional information. So the first area that we really started in was youth suicide prevention. And so as Anne had described, we were doing a lot of infectious disease work. And then what happened is the Apache tribe that Dr. Santoshan was working with, we're starting to see a cluster of youth suicide, and they really didn't know what to do. So they reached out to our center. And our center assembled a team of folks to really try to work with them using a community-based approach to figure out what the best solution was. And interestingly, it's not really on this slide, Family Spirit actually came out of that because they really, the tribal partners really realized that healthy families were really the best way to, they believed, prevent suicide. And so that was one path that they went down, very upstream to prevent suicide. And things were kind of, ended up being quiet on the reservation for a few years, and they experienced a few more clusters again later in time in around the 2000s. And that's when this program that I'm going to describe now, which is an award-winning program, really started. And as you can see on the slide, it has a whole host of components. So it uses a public health model. It's multi-tiered. We know suicide is complicated, and not one intervention is going to bring us to zero suicides, even though we would wish it would. And so the foundation of their program is really suicide surveillance. So everyone in the community is mandated to report any suicide ideation, attempts, deaths to a task force. And that allows the tribe to have really great data. And the data helps them do a couple of things. It helps them identify what solutions, because they can see who's most at risk. It also gives them power to get funding, to bring in extra resources, because they can show the need in their community and track change. In addition, what they did with that surveillance is it wasn't just about the data. So everyone that has a surveillance report come in on them also gets a follow-up visit by a community mental health worker. And both Ann and Victoria have described that model. And so those folks will come and they will try for a period of 60 to 90 days to make an in-person contact with the at-risk individual, to hear their story, listen to risk and protective factors that we can learn what's going on in the community, and then connect them to care. Because we know in many of our tribal communities and partners that getting to care can be hard. It might be for stigma reasons, there might be transportation barriers, maybe there was bad experiences in the family. And so our community health workers really talk with the youth and their family about that and try to help them problem solve those barriers to really make that connection to care. And they also will connect folks to traditional healers or church counselors in addition, really to honor their cultural and spiritual preferences. So that's really the foundation of this system. The other thing that's really unique about it, we do have some definite, you'll recognize if any of you work in mental health, sort of like the assist as a gatekeeper training, so really targeting, identifying kids at risk. There's a whole host of those parts of the program. But the other part that's really unique is the elders component. So that's the other thing, because I know we're trying to also highlight resiliency today. Our staff, as you might guess, could experience a lot of burnout, right? We know working in mental health is a really hard area, and suicide prevention especially. And they know the folks in their community that are dying and attempting, so it's especially hard. And so they had an elders council, which was really just meant to kind of inform the work, but that elders council ended up being mental health promotion for our staff, which was wonderful. And then those elders decided they wanted to develop their own program. They were willing to go door to door. They were willing to go into the schools and teach about culture and resilience and Apache values. And they were also willing to go door to door for these at-risk youth and families and try to do some of the same things. So anyway, these are, again, in very brief, that tries to give you a sense of the program. It's very comprehensive, and it's really been going on, these interventions, besides the surveillance, since about 2006 to present day. There we go. So one of the things that we had is, as you can imagine, you can't do, it's really hard to do a randomized trial, I should say you can't, in suicide prevention, right? The kids are at risk and it's hard to give a minimal amount of things. But what we had was a natural experiment of sorts. So as you heard me talk about, we had that surveillance data, and they were doing surveillance for many years before they started doing this whole host of programs that I just described, the tribe. And then they had the surveillance data sort of while all these programs were happening. And so hopefully you guys can see that on the slide there. You'll see that the bars on the left-hand side are sort of that pre-intervention time period, and the group of bars on that right-hand side are once the programs are taking place. And what you'll notice, even if you can't read the numbers, is you'll notice that the other rates, so these are rates among U.S. whites, U.S. all races, and the IHS All-American Indian Alaska Native rate. Those are those other bars. They stay the same or go up a little bit over the two time periods if we just look. And what you'll notice is the Apache rate, which is the red or orange, this is kind of a red, really goes dramatically down, providing some evidence, maybe, that this comprehensive program is really working. Now, is it zero? No, the rate's not zero. So we do have a lot of work still to do. But I think it gives hope that what this tribe and some other tribal communities are doing is really working and helping. So what happened as a result of this work is we were really lucky to be awarded by the National Institutes of Mental Health one of 3 hub grants in suicide prevention. And so it's really great because that has not, they haven't put many American Indian specific suicide grant announcements out, but they have been in more recent years, which is really wonderful. And so we are one of 3 hubs that's gonna allow us, as you might imagine, other tribes would hear about this work at conferences or through their informal networks and wanted to replicate what the Apache were doing. But as you might imagine, tribes don't always have resources. Some do and some don't to put into this kind of program or to get the training from our team. And so this hub grant will really allow us, you can see there to the tribal partners that we're going to really be able to expand this work. And all of those groups are interested in replicating the surveillance system, the community health worker model, and those follow-up visits, which we really believe are very powerful. In addition there, you can see we've had outreach as well from other tribes and some contracts with them. So as the video showed, the suicide prevention work also is expanding across the country. So I'm going to shift gears from talking about suicide prevention to give you kind of a sense of our programs to diabetes. So as you guys know, diabetes is a huge problem among our youth all over the country and especially in Indian country. And so our tribal partners were really saying, this is something we need your help with addressing. And so here you can see the different components of the program, but I think the part that really makes this program unique is the family health coach model. So it's the youth and a family member or a support person, it doesn't always have to be mom or dad, participates in all these lessons. And it's really positive focus. They're learning about nutrition and fitness and doing activities together. Their community health worker just also helps them with other kind of life problems or needs that they have. It's just another supportive person. And then in addition, there's wellness activities in the community that these and other families can participate in. And what you can see here is we have some promising outcomes from this program here. So kids are having better nutrition, improved physical activity. You can see here it's even translating into physical changes in their body, right? So they have better blood pressure, better BMI and A1C. In addition, they're reporting better mental health, right? This makes sense to us. When we feel better physically, it helps us to feel better mentally. And it makes their family stronger. And we even started to see that their support person's health behaviors were getting better too. It makes sense, right? If they're participating in the lesson together, both of them are getting healthier, which we would think would lead to a nice sustained change. So we're really proud of that program. And the community loves this program. The other thing that they did is they really got a lot of great youth feedback when they developed the program. And I know we're all trying to do that, but this program really did a great job. And they had avatars as part of it, trying to be youth friendly. So another program that I'm going to talk about that was highlighted in the video too is our Youth Entrepreneurship program. And that's a mouthful. I can never quite get it out. But what we started to realize is this actually came out of the suicide prevention work too, is we did a lot of quantitative and qualitative work on risk and protective factors. And what we really learned in our qualitative interviews with youth, and this isn't going to be surprising to anyone, but youth were saying that that they didn't have a lot to do, and that was leading to some of their engaging in drinking and other high-risk behaviors, that there was sort of a sense of hopelessness about their future, or just not quite sure, did they want to go to college? If they did, how would they make that happen? What would be other options if they didn't go to college? So we were hearing this in the words of the youth was really powerful. And we became aware of this kind of training actually happening in Baltimore City, and we're able to see it in action, and thought it would be really powerful to bring this to the tribe, to really teach the kids on the reservation about what can your future look like. If you want to go to college, here's how you get there. If you don't want to go to college, here's other career paths. Teach them about business. At the same time, throw in life skills training, right? Because if you have them there, you can teach them all of those things. And we're in the middle of evaluating this now, right? And so hopefully, we're optimistic because our kids love the program that we'll see these changes, but we'll keep everyone posted. And so we're looking at educational outcomes. And we have some preliminary data showing that the youth who are in the program are missing less days of school, have a greater interest in college. So we have some preliminary outcomes around that. We want to also see too if it just changes some other behavioral and mental health indicators. And we would guess that in the long run that this would prevent things like substance use and suicide would be our hypothesis. I must be very gentle on my touch here. Thanks, Victoria. So then the other program that we're doing during these teen years is really focused on sexual and reproductive health. And so this might be different again in different reservation communities, but what we were learning from our partners is that youth were not learning about this in school. It was not at all. There wasn't even an abstinence only or any kind, there was no kind of program at all. And we were starting to see in the adult population higher rates of STIs and HIV. And so we wanted to, again, with our prevention approach, start young. And then we also know from Anne's description of the Family Spirit program that there are high teen pregnancy rates. So all of this data together really brought us to the idea that we really needed to bring this information to kids in the community. And how could we do this? We also needed, though, to wait till the community was ready, as you can imagine. These are hard topics to talk about. Suicide, too, and sexual education are, the community has to be in the right place. And so they finally were. And what we decided to do, instead of going into the schools, we have a camp in the summer, right? So we also know kids in the summer don't have as much to do in the reservation communities we work. So it gives them something productive, proactive to do during the summer, gives them an activity that they love, basketball, and then they can learn about their health. And so the boys and girls are separated so they can learn about their different reproductive health. And the program is very hands-on. I mean, the kids learn about how to put on a condom. They have to practice it themselves and use the skills, because what we know from the literature is that's what's actually gonna be the most helpful. It's not just hearing about it, but actually that idea of practicing it. Because we know it can be embarrassing for a new, someone newly engaging in these behaviors to initiate that conversation with a partner. And so it's really hands-on, and the kids love the basketball. We sort of joke it's sex and basketball camp, but the kids love it. The kids absolutely love it, and they're learning so much. And even our staff in the community, it's very fascinating. They will reflect back to their own childhoods and say, we didn't learn about this, and we're actually learning stuff by participating in this. So I think it's bringing kind of the level of the parents and the leaders in the community and the kids higher so that they can be healthier in this way. And so the next steps really in this program, again, this is currently being evaluated. And unfortunately, this was one of the programs, there's sort of a host of grants that have supported this over the year in different iterations. But one of the grants that you may have heard in the news is one of the ones that was cut, unfortunately, with sort of the funding cuts that have happened recently at the federal level. So they're looking for other ways to kind of continue this program. But they really want to bring parents in. Because you can imagine parents are key, right? Parents have to feel comfortable talking to their kids about sex. Kids have to feel comfortable going to their parents. So they think if they can do this with like a community health worker can kind of coach the parent and kid together to engage in these conversations, that will make it even more powerful and more effective. So they will have some outcome data, but hopefully everyone here can send good vibes our way that we'll keep continuing to find funding for these kinds of programs. Thanks, Victoria. Then this next part actually shifts gears big time. So if you'll notice on the slide, I know this might be the part of the presentation where people start to kind of, get sort of restless, but this is actually a program focused on adults, okay? So everything we've talked about before has been, teen moms, early childhood, teenagers. But we realized that there's also a need to work with the adults in the community that are engaging in these high-risk behaviors. So here you can see it's a very similar to the program I described before, but it's really, we know that high-risk behaviors cluster together, even in kids, and it can be the same in adults. So folks who tend to engage in binge drinking are also at higher risk for getting an STI and might also be at higher risk for suicide. So instead of for the adults having 3 different programs, the idea with this program is to have one that really targets all of those risks. And each individual might have different levels of risk in those behaviors. And so you can see here what it does is it uses that surveillance system to sort of get the folks. That really helps us to find folks in the community at risk. And it provides 12 brief sessions of one-on-one counseling. Really, again, just to think about that, what are their high-risk behaviors, understand a risk score, like how at risk are they really, how are they normatively in the community. Tries to get them to actually do some screening to see if they have an STI, and you can see here there's a kit that they can use that's self-administered, which we know increases rates, because it can, for anybody, it can be embarrassing to get those tests at a clinic, and while that would be ideal, we can use self-administered kits to fill the gap for those who might not want to get screened in the clinic. And so you can see here we're in the middle of a randomized trial now, again, and you can see some of the details about that trial. And again, we'll continue to try to disseminate findings from all of these studies. So lastly, a sort of a new area on the horizon for our center is preventing injuries in Native communities. And we really, from our partners on White Mountain and Navajo, have seen the need for this. Especially with motor vehicle accidents and other kinds of injuries, they have reached out to us, and Anne on our team is really leading this effort to sort of figure out, first of all, what are the injury priorities to get the data. Is always important. So they're in the middle of doing a needs assessment around the data right now, and hopefully going to use the epicenters as a sort of a good key partner. So our center also tries to partner with other important agencies in the community doing this work. And really to start a coalition. So like you heard in some of our suicide prevention and other work, it's kind of our model to do that. To have the community want to address this problem, help them gather better data, get community partners together to then design the solutions. And so this work is in an early phase. So again, that is the end of our presentation today. And we really appreciate your time. And we do have a website. I know that we went over a lot of information and tried to give you guys an overview. But you can always go to our website and check out for more detailed information and program contacts for any of this program. And we hope that you'll leave sort of feeling a sense of the burden and the issues, but also a sense of hope that there are lots of great programs going on that are making change in our Native communities. So thank you all.
And I think if it's okay, I'm Kitty Marks, the Director of the Division of Tribal Affairs, and we have a few minutes, and we appreciate everybody attending today's presentation, and we want to thank all of you for your great presentation and coming here. Are there any questions to our presenters? Dr. Carroll?
Well, I want to thank you guys for coming, and I do really appreciate the work that you're doing. In my former position as IHS CMO, we really worked hard on the Family Spirit program. And one of my other passions is breastfeeding in our communities. And I'm just wondering if Family Spirit addresses breastfeeding as part of nutritional support, prevention of diabetes, prevention of everything that breastfeeding does. And just to see if there's been any connection with the Baby Friendly Hospital Initiative and IHS and across the country.
Yeah, so there is several modules focused on breastfeeding, and we have a lot of problem solving around it. So if there's a mother that wants to breastfeed and is facing challenges, really work with her to figure out what to do. And when you asked if we have links with some of the IHS hospitals, Chinley popped right into my head, because I know that we've been really working closely with them to make sure our moms access the services that they have available for breastfeeding.
How about with Baby Friendly itself? Any connection there?
You know, I'm not sure, honestly, but I will say I talked a little bit about the new RO1 that we're doing. We're enhancing some of the early child nutrition aspects of Family Spirit. And I know right now we're doing a lot of formative work and curriculum development, and I do believe we are working on that.
Great. Thank you.
Any other questions?
I had a question about the suicide surveillance. So I thought I heard you say that like all members of the community are involved in that. So can you speak more about like, are people trained in terms of what to look out for? And then I'm assuming there's a place to report.
Yes, I would love to tell you a little bit more about that. And so, as you might imagine, to get community-wide, it really is community-wide reporting, took time, right? And so what it started out with, I think this helps you to understand the sort of the trajectory, is that it did start out with professionals being the first reporters in the early years of the surveillance system. So folks in the ER, folks in social services, mental health, the schools, for the reporters. And they did get training. And so first of all, just because there's a tribal mandate, it doesn't mean that tribal police are going around and punishing people that aren't reporting. It just means that there's this tribal importance of folks doing this, and that we can go into the different departments. So our community health workers will go in once a year to each of the departments and do what they call in-services, these educational opportunities to say, here's the problem in our community, showing them some of the data, here's the mandate and why the tribe did it, here's how to report, here's some basic information about suicide. So they go in and do that, because as you can imagine, there's also a lot of turnover, so they try to go once a year and do that. But in addition, they expanded the mandate really to be any community members. And so, I wouldn't be Apache, but if I lived on the reservation, I would be, and wasn't a professional per se, I would still be required to report. And so over the years, we really have seen that kids report on their friends in a way to get help, that folks will actually call to report on themselves and their family members, and we've seen an increase in that over the years. And so the way they get that out is they go on, they we'll have an article in the local newspaper, they'll have information on the radio station, they'll go to any kind of community fairs, health fairs, events to kind of get the word out about reporting. And so it's really been an effective approach. Hopefully that answered your question.
Another question, sorry. Because it's such a great program that it always stimulates ideas for me. One of the things now that as part of the Division of Tribal Affairs, we're very excited about including some of Medicaid enrollment with some of the teachings that you're doing, most specifically, I guess, with Family Spirit. I guess, who do we talk to? How do we get involved with that to add maybe a slide to the 63 Family Spirit program booklet that is taught?
If you want to email me, we can share the information with our curriculum team, because I think that is very important, and we can make sure that.
Great, thank you.
Right, and as the Division of Tribal Affairs, we encourage American Indians, Alaska Natives to enroll in Medicaid and CHIP, but I think so many of your programs, you're funded through grants, that even as maybe we can work with you further to see how your programs could actually enroll as Medicaid providers to help sustain your programs. You mentioned there was funding cutbacks, and so there might be opportunity to see how many of these programs, a lot of them preventive services that are probably covered under Medicaid, and how these individual programs across the country could become Medicaid providers. So.
I had one question. Under your addressing the triple threat, substance abuse with STIs, and suicide risk, I noticed that there was one bullet that talked about the collection of STIs during the home screening. So how are you collecting the data for someone who's screened positive? Is it just because they came into the office to be treated, or what if they don't seek treatment? I'm sure they probably will, but what if they didn't?
Yeah, so this is, and Anna Victoria can chime in too, and hopefully I think this will address your question. So I mean, this is, that part is for folks involved in this study. They have that option of doing that home screening. Mm-hmm. But yes, and it's interesting because it gets, we actually have someone at they get mailed to and they get the results, and so then the results have to get back to the community health worker, right? Okay. So the community health worker will find out if they screen positive and we had to develop a whole protocol, which as you can imagine was quite sensitive to do, about how to inform them of their findings and encourage them to get care. And so it's part of that visit, and they're even though it's they sort of do it at home and the results are sent back, our health workers are aware of who screens positive to kind of make sure that they discuss that with them and help them get care. I don't know if that kind of answers your question.
So does the health worker follow up as well, just to see, because they know the person took you home for screening, so the health worker follows up to see what the screening what were the results of the screening?
Yes.
Okay.
Yes,
that's
because they're sort of
helpful.
working with them, as you can see here, too, through these 12 sessions. So they have a relationship with them, luckily. I mean, it doesn't mean that everyone's going to want to engage around it or talk about it, but
Right.
you know, if they're going to want to talk with anybody, hopefully it would be their health coach that they're
Okay,
working with for
that's-
12 kind of sessions. So at least it's integrated into that as opposed to just being like a totally
Like
sort of
sent home with the text and no one follows up and,
Yes,
and then you're
exactly.
relying on the patient to report back. So, okay. So
And quite a few are willing to do this method, and I
Okay,
think they're
that's
they're
helpful.
writing some manuscripts, and we would be happy to send whoever the best point person is here, some, you know, related articles about some of these programs if anyone had more interest.
Okay,
So,
great. Thank you.
Anyone else? Okay, well, thank you again. I'll go ahead and turn it over to Patrick Squire to make some closing remarks.
Well, good afternoon, everyone. My name is Patrick Squire, and I am the American Indian and Alaska Native Special Emphasis Program Manager in the Office of Equal Opportunity and Civil Rights. I would like to just share a few remarks in closing. Each year, CMS observes American Indian and Alaska Native Heritage Month to commemorate the contributions and accomplishments of American Indians and Alaska Natives. Today's program was not only entertaining, but highly educational. The presentation was eye-opening and exceptional as it really gave us an insightful glance into the history and culture of the American Indian. I really hope you enjoyed today's program. I know I did as well. American Indian and Alaska Native Heritage Month is the special emphasis commemorative event that CMS recognizes each year in support of the agency's Equal Employment Opportunity Program. This program's goal is to promote cultural awareness, including valuing cultural diversity and other differences, such as race, color, national origin, disability, and gender, with the goal of fostering an environment in which diverse people work together cooperatively and harmoniously to achieve organizational goals. With that said, I would like to thank our panel of keynote speakers, Dr. Cwik, Dr. O'Keefe, and Ann Kenney from the Johns Hopkins University Centers for the American Indian Health for sharing with us this valuable information. I would like to present all three speakers with certificates of appreciation on behalf of the Office of Equal Opportunity and Civil Rights as a small token to thank them for their participation in today's program here at CMS. And so I'd like to present you guys with some certificates. Thank you. Thank you. Thank you. I would also like to thank our program sponsor, Dr. Gifford, from the Division of Tribal Affairs, and the American Indian and Alaska Native Employee Resource Group for their collaboration and success and execution of this program. Thank you very much. I would also like to extend a special thank you to all of those who supported this program, including the Office of Communication and Judith Coble from the Graphic Design Services. CMS's American Indian and Alaska Native Employee Resource Groups focus on working to assess barriers to equal opportunity for CMS Native American and Alaska Natives. This employee resource group also seeks to increase opportunities for outreach, education, and development within these communities. We hope that CMS employees who are participating in the audience from today's program will share this information with their colleagues. We welcome CMS employees to participate as volunteers in the employee resource groups and encourage them to bring their ideas to make a difference for our CMS community. If you are interested in volunteering your time in American Indian and Alaska Native employee resource groups, please contact me via my email at patrick.squire@cms.hhs.gov. CMS also has other employee resource groups. For additional information, please contact our resource email or mailbox at erg@cms.gov. Please remember that the Native American Vendor Fair is happening today on the first floor of the central building in the atrium. Please stop by and show your support, as this will take place today, tomorrow, and Thursday. And last but not least, to all of you here in the Media Center, also in Bethesda and in Washington, D.C., and also in our regional offices, thank you for participating in this valuable educational and cultural experience. We certainly hope you enjoy the rest of your day today. Thank you very much. And that'll conclude the program.